This is the No Stroke Podcast with your co-hosts David Dansereau and Michael Garrow, helping you to support and thrive in life after stroke. Their podcast is designed for educational and community support purposes only and should not replace medical treatment and guidance of your own health professional team.
Welcome to episode 76 of the No Stroke Podcast. My name's Dave Dansereau, and I am here with my co-host Mike Garrow on a kind of a snowy morning here in New England.
Yeah, rotten. But listen, you just gave the countdown, for guess that don't know, right? Behind the scenes, it's a 3, 2, 1 countdown to get us going. We're in the fancy studio, man. You have the 3, 2, 1 automatically there. No need.
I know. I'm still old school Zoom. Sorry.
No, but yeah, it's winter's here, David. Winter's here. The one thing I'm excited about is ski season. So hopefully be able to get out, and whether probably not out west. Still haven't been able to get out there, but definitely get up to Killington or somewhere up north here in the Northeast.
Skis waxed up and make sure the helmet's nearby. We had that conversation last year, right?
Certainly the helmet. Yeah. I've had some scary moments.
Well, here we are. Again, we kind of surpassed a little bit of a milestone last week. At least our Buzzsprout hosting account said that we hit a badge for 75 episodes. So here we are at 76, pushing forward.
100 around the corner, Yeah. I think we'll be able to do it this year. Or 2025, should I say.
2025, yeah. Whoa, yeah. We are in December, Mike.
Yeah, in the next 12 months.
All right.
Next 12 months. But yeah, it's, last episode, just want to give another shout out to Dr. Rachel Foreman for coming on the pod. I think it was a great discussion, just, with these updated milestones. Can't believe it's been 10 years since, there's been an update in the stroke prevention guidelines, but she did a great job to kind of walk us through what those updates mean. Obviously, new things like GLP-1s on the market, a higher focus on social determinants of health, which we'll be diving into a little bit more next episode with some of her peers at Yale, as well as a neurologist up at MGH, who are doing a study more on looking at well-being and social determinants of health for both risk and then like post-stroke outcomes, which is interesting. And then, which hasn't, I think it's always been known, but not a specific call out on the guidelines around the risk factors, women need to be thinking about, especially like during pregnancy and postpartum as well. So I think that's a topic area we need to dive into a little bit more and potentially cover early in the new year, as it's still, kind of top of mind in this prevention theme. I guess we've been on for, a couple episodes, but yeah, important conversation, and shout out to Stacey Quinn, previous guest.
Absolutely.
And she had some nice words to say on LinkedIn about the episode, and does her own role really to encourage advocacy around stroke prevention, specifically women's risk factors as well that need to be concerned. So thank you for those kind words, and noted. We'll do some more episodes around that.
And sharing. It's invaluable when we get that feedback and then a share of past episodes.
Yeah, totally. You've been busy yourself. I saw you were down at an event at URI recently.
Yeah, the last 2 weeks, one night last week, I was invited to an alumni, and I do some mentoring down there. So they put on a nice dinner, and it was a way for young pre-PT students to get to ask questions. Many more juniors and seniors at the university, and we're considering moving on to a career in PT. And then the following week, I was back down there. Just last week, I was presented to first years on knowing stroke and kind of talking through the lived experience, things that you might not see and what happens sort of with the stroke survivor and their family behind the scenes. So hopefully they take that in consideration when doing a history. And I'll just add, I shared with them, walking down those halls that I graduated down there some 20 plus years ago, when the very first time we got our hands on patients down there, I'd say hands on, but we're trusted to able to work with groups we were co-treating. And the very first patient actually I worked with in clinic at URI was a stroke survivor. And he and his wife came in, and he had aphasia, and he was very much impaired, just returning to be able to walk. And I remember thinking, and I shared with the group, that I thought that was the hardest population I could ever work with. The tools that were, and it kind of maybe leads a little into the discussion we're going to have with the guest and interview, is the tools that we had in clinic were not probably optimal. And it was very heavy lift to try to work. And I almost, I walked out of there thinking, I'm going ortho, sports med, anything but neuro, and here we are today. And, once you've lived it, you realize that and that's why we're doing this, right? You realize that there's still such a need. And so thank you to the students who jumped aboard and picked up maybe a couple episodes of the podcast, but had some great questions. So that's kind of what I've been up to in the last 2 weeks.
Inspiring the youth, David. Inspiring the youth. It's it's a tough field or tough discipline, I suppose, within the overarching PT or OT field, right? To deal with the neuro population. But I think it also drives some of the best, right? Because people are up for that challenge, right? Of dealing with this population. So
that's a really good point, Mike. Your heart, the neuro PTs that are in it because they're in it to do more and better, are the one that's who you want treating you.
Yeah. And I think today's guest is a prime example of that. So, in this episode, we're going to be joined by Vineet Johnson. Vineet's a licensed physical therapist amongst, his many other degrees, certification. One of those guys with a very long list of abbreviations after his name. But he's a turned entrepreneur who's doing some groundbreaking work in the stroke rehab space, based up in. Let me get this right. I'm not going to get it right. It's north of Toronto, so he's up there in Canada. But he's founder of a company called iRegained, and today Vineet shares journey from academia to designing this MyHand System, which is a device that really does a good job at combining gamification in rehab, right, which is that overall kind of motivational factor behind keeping people engaged, with data tracking, not only just for the patients, obviously, to see their progression, but the important side on the clinical side, and ultimately getting back to the insurers who are going to pay for this. And he really brings this through is design thinking, right? So how the patients and clinicians were top of mind from the initial kind of prototype design all the way through what they have in this phase right now. So really, really good conversation. We talked through the challenges of where he's at right now as a small startup, navigating funding, insurance, how this is going to get reimbursed, and also having clinicians educated around this. I think one of the areas I loved where this conversation went, though, was around clinical trial access, and we've talked around clinical trials and how great they are for patients to be able to seek alternative treatments and therapies, but there's also that barrier that seems to be there. One, with people being able to learn about these trials, so just overall the education around clinical trials, and then actually the enrollment. So Vineet does a great job, kind of brings us behind the curtain of a academic turned entrepreneur who's kind of really knows this research space well, and just the factors that go into clinical trial design, and opened my eyes to a lot of stuff I didn't really understand was there. So yeah, I think everybody's going to enjoy this conversation. But as always, we've another guy who just brings a lot of optimism
Yeah.
to what's coming in stroke rehab.
And again, I think now another innovator with PT roots and foundation. I think now the PTs probably surpassed the OTs by a little bit in terms of the folks that we've had on Spotlight. So we'll have to have some more OT innovators on. But
Yeah,
I just,
Lauren,
what this is.
Lauren Sheehan, can do. I'm looking
Yep.
at you
Yep.
right there.
Okay.
We got
Yeah.
to
There
get
you
her.
go. Ping us. Just Mike, this is another one for our audience that you definitely thank you that you stepped up and took the lead on this. This is one that you just, I wasn't able to be there for the recording, but I did, listen in, and I share with you. I happened to be at my lunch break listening to this, and Vineet was talking great examples of neuroplasticity. And as I'm listening to the episode, I had someone doing excavating work in my backyard. So I'm listening to the episode, watching this, fascinated by this young driver, probably around your age, young Mike, whipping this backhoe with a claw, with a thumb, and I joked with him after. I said, "You could probably do this blind, right?" And he was, "Yeah." He goes, "I grew up on this, sitting on my dad's lap from the time I was about 3 or 4 years old." So I said, "So you could close your eyes and I could tell you to move that bucket a foot over and then drop down and grab something and scoop and lift it back." It was yeah, all day long. And at the same time, Vineet was talking about the intricacies of picking up a cup and the protocols needed to be specific and functional. And I was just like, wow, here's a perfect real world example of neuroplasticity, having that volume of work and being able to now do a task that is like second nature. Whereas the relearning, when a stroke impacts those neural networks, that has to come back to, enough volume, enough, that I know the topic of gamification and task specific came up, and that's those are tools for driving neuroplasticity.
100%. Yeah. Perfect way to kind of get into this one, David. So yeah, I think, as David said there, think about these things, just your day-to-day tasks. And as Vineet describes, his technology and what he's doing, I think you'll see, even if you're just listening and not able to kind of go in and look at the device itself, which I encourage everyone to go do, is check out his website at iRegained. What is it? Let's see.
.rehab.
iRegained.ca.
CA.
We'll drop those links in the show notes, but you'll be able to see the device. Whether you're a patient or clinician, reach out. They work on a kind of trial basis where they could get this device into your local practice, in 30 days, no cost, and try it out, see how effective it is. But yeah, I think it's something that could be revolutionary here in the space. So you heard it here first, potentially early stages. But yeah, look, I think these type of folks are who we need more of in this space, yes. Right? So yeah, super promising to hear what's out there. And it's not just fluff. You could go get it, right? It's a device that's ready for use. So I encourage everyone to go reach out. Share this episode with folks who might be interested in recovery, the post-stroke space, especially upper arm mobility. And stay tuned. We'll be having hopefully one more episode here before the end of the year. But if we don't hear from you, happy holidays. Rolling into the new year. Give me one goal for 2025, David. What do you got?
2025. I'm mastering those drums, at least 2 songs. That's my personal goal. I've been talking about it for years, but it's going to happen. Maybe live. Maybe live down in my workshop. You haven't seen the angle on the workshop. I got sequestered. The drum set got sequestered to the workshop in the basement. So
love it.
How about you? Right. How about you? Quick one for you. Come on.
I'll tell you in 2025.
All righty. You're working. Work in progress. All right. Enjoy this episode.
All right. Hi, and welcome to the No Stroke Podcast, Vineet.
Thank you, Mike. Thank you so much for this opportunity. Really love to talk to you. Yeah, it's been a couple months now since we connected, and we had a couple conversations here. So I'm glad we're finally doing this. And before we started recording, you mentioned a couple exciting milestones for you. So we'll certainly kind of dive into that. And always great to have an innovator on the podcast, right? Stroke often is a an area where there's not much attention, and from a funding perspective, and just overall, like, you see so many people with lost hope after a stroke, right? And it's people like you who are thinking and trying to bring innovation into a space that's really hard, but needs it, right? So really excited for this conversation today. But before we get going, why don't you just, for our listeners, kind of give a bit of a background, your early, we don't have to go back to birth, but let's, bring a journey to where you are today.
Yeah, that's still going to be a long one. I'll make it as short as I can. I have a couple degrees in physical therapy, couple in neuroscience, uh, a decade, a career spanning about 32 plus years now. And when I started, I was very fortunate to have a professor. I was an undergrad in physical therapy, and this is a professor in neuroscience. So my daytime, I was doing my degree, and my evenings and nights, I was working with him in neuroscience, kind of moonlighting without getting any credits for it. But it was so intoxicating. At lack of a better word, I'm addicted to neuroscience because of him. Probably the greatest teacher of mine ever. And the thing I learned, his focus was understanding control of hand. How does the brain control the hand? So for me, it was more along the lines of why do people hold pens differently? Why do people walk differently? Like that was my urge, like why? Why can't we all hold the pen the same way? And that quest is why I went to all these degrees and everything, so on. But as I'm understanding more control, I'm also understanding what happens when control disappears. Because if you think of a stroke or a brain injury, a part of the brain is damaged. And that whole software of learning stuff is wiped clean. How do you put it back? And that took me down the robotic pathway. I was part of teams that built about 4 robots from scratch. And I realized if you want to learn to do something, if you want to learn to play tennis, you pick up a racket and hit the ball a million times. If someone told you, no, put a stimulator on, it'll twitch your arm a million times, or put a robot on, it'll move your arm a million times, and somehow you'll magically learn tennis, you would laugh at it. Yet that is the status quo. And we at iRegained want to change that. Because for any meaningful neuroplasticity to happen, people have to do it themselves. So, long story short, quit my academic career and jumped on this process of a startup. I figured, with 20 plus years of teaching experience, somebody will give you a part-time job. The only people who would give me was Uber and Amazon. So I was a cab driver and a delivery driver for 2 years to get this company going. Lo and behold, today we have a product that is patent received from US and China, clinical validation complete, FDA registration complete, compliance testing complete, and as I told you earlier on, our first product is now sold, and it's actually being used in a hospital, and they love using it, and that period is priceless.
Yeah. So to have that journey, right, and now see patients using it, and aiding their recovery has to be a big milestone for you, and just something to be proud of, right? But to be an entrepreneur, you have to be crazy, and to be an entrepreneur in healthcare, and in specifically stroke rehab, you have to be even crazier, right? So bring us through that, like, early concept design. You spoke to some of the research that you were doing, and really what drew you into movement as the focus area. But when was, like, the first spark of saying, well, this needs to be brought to the wider mass. This needs to be a product, a company, and ultimately what you started with iRegained.
Okay. That's a very intriguing but very interesting question. Nobody's asked me that before. As I told you, my interest was trying to understand what is control.
Hmm.
Like, why do fingers move the way they do, right? If you think of, from morning till now, you must have used the hand in probably 200 to 500 different configurations. We just don't realize. So when I was working with the robots with patients, I realized when patients were interacting with the robots were providing assistance or support systems. And the patient themselves are not able to benefit directly. In other words, I had to tell the robot, do only this. And there came a point I realized it, there shouldn't be a robot. I got to take the robot out of the robot. And from there, I went to the next step where I basically had 5 sticks, 5 fiberglass sticks, one on each side for 4 fingers and one on this side for the thumb. And each of them at the bottom, at the very tip of it, had a cut end of a glove, which was the finger cup. And that was what you call the concept device. And from there, we went into that. Then we motorized each of those movements. And then we tried another fascinating concept. It gave us everything we wanted, but we couldn't miniaturize it. So from there, we moved to this, which was perfect in every way. But as you notice, it's bulky, large. And we miniaturized from there to here. From here, we went to about this much, about 10 inches. 10 centimeters, about 4.5 inches.
Hmm.
And so that's from there, about that much. From there, we went into a device which you could put it on a laptop right now. And the process was done in such a way because patients shouldn't have to go to a device. If you look at a lot of robots, they will kind of twist your arm out and tie it up in front. When you do that, you've already reduced the range the patient can move. Instead, if the device goes to the patient and they can only move, let's say, 1 inch, you could use that. So the device was devised at every step with the patient in the center, with their function in the center, with their comfort in the center, and with what clinicians would want as fundamental ease of use.
Right.
Because you don't want to put a technology that somebody has to sit and learn and master. It should be like, 2 clicks, 3 clicks, you should be able to get to where you need to get to.
Mm.
And while you're doing therapy, for example, let's say you're working on a task, your goal is to train how to do this. And let's say the one finger got stronger than the other, and you want to add more force to that finger. All you have to do is just one slide and say, okay, and bam, next second it's ready to go. It makes the clinician life better, patient life better, and most importantly, you could see what granular changes are happening in real time, and they can respond to it. So that's kind of the whole concept pathway.
Yeah, and I just love the point that you made, around designing with the patients and the clinicians right there, because oftentimes so much in technology innovation, it happens in a siloed box, and then something comes out and they try to find the problem for a device or something that's already there, right? So
You
yeah,
bring a very interesting point. That's something I constantly say. 99% of all rehab devices came from engineers,
yeah,
and engineers think in straight lines. Nothing about the human body is straight. The one fundamental difference between iRegained and all the other technology out there is the fact that we do not think anything in straight lines. And everything, like you pointed out, is patient-centered, clinician-centered. That's it.
yeah, and you touch on that, and for the people watching, they might be able to see some of the devices and kind of stages that you've gone through as you were pointing it out there a couple minutes ago. But for the folks who might just be sitting or going on a walk, doing their workouts, and listening to this, can you maybe be a bit more descriptive of exactly what this device, from a patient and a clinical perspective, like what that journey is, what the device actually, feels like, with the operations to kind of use it in a sense, right?
Yeah, that's a good way to put it. Let me start with a fundamental example. If someone wants to learn to play tennis, they have to pick up the racket and hit the ball a million times.
Mm-hmm.
When they do it a million times, their eyes, their hands, their arm, their shoulder, their hips, their knees, their feet, you're constantly moving around, dealing with the environment, which creates neuroplasticity. Neuroplasticity is an entity that's a configuration of things put together. If you think of what is your memory of eating a mango or think of any fruit or ice cream or whatever, you will remember the place where you sat, the flavors, the smells, the noises. Very similar to that, movement neuroplasticity, all of these things have to come. And in real time, think of picking up a paper cup of coffee. It has a certain weight, a certain heat. You can't squeeze it too hard. You can't squeeze it too little. It has to be just right. You cannot burn your fingers.
Mm-hmm.
You don't even think about all these things, but all those factors has to come in. And when that happens, you have something called neuroplasticity. And from that logic, in the device that we have, for example, if you want to train how to squeeze a ball, squeeze an orange, hold anything, ball shape, your fingers have to be like this. In most rehab, if you notice, the fingers will be like this. But for you to have effective neuroplasticity, the fingers have to be positioned like this. So all these sensors will tell the brain where the fingers have to be, and all the muscles have to control and contract in those positions.
Right.
Only then that functional ability comes out. So our device allows, let's say your hand has 100 functions. You could set each function in those respective positions. So when you can train those muscles, those sensory information goes to the brain, and the motor information from the brain comes back down, and you're controlling it at that granular level.
Mm-hmm.
Number two, whether it's left side or right side or 6-year-old child or a basketball player, it accommodates to all these sizes. And the other important part, because of the way in which the device is designed, let's say if someone says, I have a guitar card like this, set me up for this, we can actually do that. So whatever position they need, we can.
Right. And it truly is like popsicle sticks, kind of, right, that are being moved around to kind of get that right positioning. Is that
Yeah,
like how
very sophisticated, but you're right.
Yeah. For someone listening, trying to understand like what it feels like, what it looks like. Yeah.
And even when you look at a granular part, like when a patient's sitting like this and the device comes to them, the arm should be well supported, because a lot of people with stroke have a lot of shoulder pains.
Right.
And that can be quite irritating for them. So the armrest goes in multiple directions, about 9 degrees of freedom, forwards, backwards, up, down, rotates, tilts, anything you want, to make sure the patient is comfortable through the entire pathway. And the movement itself, for any neuroscientist listening to this, the movement is 100% friction free. Because when you think of movement, there are these things called muscle spindles inside your muscles. They record changes in muscle length, changes in velocity. And when they record, let's say you have friction in the system, like a lot of robots have a lot of friction in the system. When that friction comes in, these muscle spindles will pick them up. When they pick it up, you're not able to put effective neuroplasticity. You're probably getting incorrect neuroplasticity. So the force delivery is in such a way, it's pretty much smooth and absolutely zero friction. So you're trying to create as much an environment close to natural environment as possible.
Cool. So you mentioned kind of, again, like really designing this with patients, clinicians in mind, the ability, I'm sure, right, of being able to have that device come right up to the patient's seat or bedside, wherever they're doing the therapy is super important. Another area, especially when, you kind of look at just overall motivation, right, for survivors continuing to do some of this therapy. How are you thinking about like gamification and some of that within the device itself to kind of, help motivate individuals?
You bring up a very, very key part in the world of rehab.
Mm.
There are tons of books and research done on this thing called exercise adherence.
Yep.
Uh, Number one, you have to focus on what the patient wants, right? That itself has internal motivation coming up. Number two, you have to show them real-time progress. Are they getting better? What am I doing today? They need to be excited about doing what it is. If it's just an exercise, there's no point, right? If you're running to train for a marathon, that's your goal. So here, maybe they want to be able to button up their shirt, zip up their pants. Fundamental task is what they're asking for.
Mm-hmm.
So number one, task specificity is very, very important. And attending to their needs automatically brings certain motivation. Third, showing them real-time feedback that shows it's their movement that is happening on the screen, right? Because a lot of times if you talk to people who had a stroke, they don't think their fingers can do anything.
Yeah.
So if you can show them clearly, this is how much you are doing. Can you feel it? That's another way of motivating. And then the last part you referred to is gamification. Make it interesting. Like, why just sit and do 1, 2, 3, 4, 5? Why not? Oh, shoot that ball into that basket 5 times, right? And throw a little music around it that says, yeah, you got 2 balls, 3 you narrowly missed. You got a score of 28. Let's see if you can beat that with the next round or the next finger or whatever the case may be. So that's how we tackled it. Once again, every step of the way, the advice on each of those came from the patients.
Mm.
So that's the angle we took.
Good.
And it's been from the feedback we're getting from the various places our devices are at right now. That's the part that actually gets the most attention, which is quite interesting.
It's important. Yeah. Just that, because there's so many different devices that are, options out there, and you look outside of stroke, right? It's just a plethora of different apps that are available, but it's the ones that, can kind of create that, it's the blend of the intrinsic and extrinsic motivation to kind of keep you engaged, right?
Exactly. So we worked on both directions, both intrinsic and extrinsic.
Yeah. So let's touch on, an important aspect of stroke. You mentioned it from the patient's end, right? Is like showing those little improvements here and there, right? Like, you are moving your finger a little bit more than you were, last week, whatever it might be. But that's even more important from a clinical perspective, right? Being able to see some of this data. So talk to me a little bit about how you're capturing data, and making use of that for both, clinicians, and then potentially ultimately like how you get this thing paid for, from the insurance companies.
Yeah, from the clinician side, they really want to know what is change and in what proportion is that change happening. Because it allows them to provide the right kind of prescriptions, patient-centric, and allows for progress to happen. Because at the end of the day, the clinician and the patient have a contract. And the contract is saying, I need to improve my function, and the other person is saying, I'm going to do what I can to help you improve that function. And this data allows at a very granular level. So if you pick a task, like holding this bottle, most of us just casually do it. But when someone after a stroke is trying to learn that, the first point, there are 5 fingers involved here. Then your palm is involved here. The number of muscles involved in making this happen, about 25 joints, 36 muscles. Now, because most of that function is not there anymore, you're trying to granularly put this function back. So maybe you will start muscle by muscle rehab, or finger by finger rehab, or function by function rehab, depending on where in the continuum the patient lies. And the device accommodates for all of that. And once you do that, the next thing is the clinician is prescribing based on progress over time. And the patient is also wanting to know, am I seeing any change, you
Right.
know. And the more change they see, more intrinsic motivation comes in. From the data side, when you look at insurance company, for example, they want to know if they're going to be funding this, are there meaningful changes happening? I think now in the US, we talk a lot about value based care. And what that means is we put money into this, are we getting some value for it? And the data allows for that value to be shown
Right.
quite blatantly. So all of the data on a very granular level is collected and stored in the cloud. The clinicians can take the data out in real time, or they could take the data out later on and look at session by session, or within a session, within the 1 hour of therapy, the patient did 40 repetitions. They can see changes between the 40,
Hmm.
or week by week, month by month, which allows them to chart a clear pathway for effective rehabilitation.
Right. Right. Right.
And that's the goal of the data there.
Okay. Great. Great. So, are you thinking about? And obviously, you're still early stage development of the device, and I'm sure the overall product offering that you see at some point down the line. But do you think about like a clinical portal of some sort that they could go in, kind of view patients progression, using the device, or is it all kind of raw data that they're getting at the moment?
Right now, it's already both are there,
Okay.
because we were also aware that there are a lot of researchers interested in devices like this,
Mm-hmm.
because there are no devices out there that could do even remotely 5% of what our device can do.
Yeah.
It sounds like a little bragging, but it's just the reality. So with that in mind, if they want raw data, they could take raw data,
Right.
but the portal's already created for clinicians separately, but they could compare between patients if they want, and within the patient if they want, from all of those perspectives. So when I said patient centered and clinician centered, we kind of took both.
Yeah.
And even the software was written from that perspective right from the start.
Okay. So let's talk. You kind of brought us through again the technology itself, the offering, how you're using data to pull together, look at outcomes. In excuse me, in the stage of where you're at right now, what have been some of the biggest hurdles that you think you've had to face and are continuing to see as kind of an uphill battle?
I guess most startup, when you ask them this question, they're going to have a little giggle and think of the million problems they had. Uh, as a child, my dad used to tell me, without risk, there is no achievement. So uh, the other thing he also used to point out was not what you do, but understanding the consequences of your actions. And so that you're weighing the odds before you do it. So going back to your question, I think the biggest challenge is funding. Uh, for some reason, a lot of investors like to invest in software, but they are not so comfortable doing that in hardware, maybe because the timelines are longer and so on. In fact, I've had some investors ask me, why don't you solve this problem with the software? And I have to explain to them, for the fingers to do, you got to lock it up. You had to have a device there. Uh, you cannot just do to the software. So the biggest challenge is funding. The second biggest challenge, when you bring a device that's completely different from everything else out there in the marketplace today, you're no more just selling a device. You're also educating in the process. And you have to be very careful on how you educate. Sometimes you're talking to clinicians or researchers who've been in this space 30, 40 years, and you have to listen more than preach, and focus on what we do at a very granular level as opposed to try and preach what the greatness is. So that's a second challenge of educating without sounding very preachy, so to speak. Those two would be the biggest one. Uh, and one other factor, like as I was pointing out at the start, we looked at the word risk at every step of the way very seriously. So you're constantly looking at where are you likely to fail,
Mm.
and how do you mitigate those risks. So that was one of the key reasons that we've reached where we did so far. And of course, we have a phenomenal team, a team that really cares about. They took the dream, they made the dream their own, to a situation where everybody is focused on how do we make this better? How do we serve the patients better? How do we serve the clinicians better? So those factors collectively reduced a lot of challenges, but I would say funding is one key factor that really has a negative impact on our progress. Even at this stage, I'm currently now raising money with the goal of expanding into the market and looking for greater support from investor space out there.
Great. Yeah. And I mean, it's stroke rehab is, yeah, especially a hardware device, right? It's a tough space to, it's an easy space to innovate. I feel like, cause there's so much that needs to be done. Right. But it's, you know, the ROI that some of these investors out there are trying to seek. It's difficult, but I think the problem that you're solving and the team that you have around you and the outcomes that you've proved so far, hopefully will prove warrant that, you know, there's a group out there willing to see the opportunity. So, you know,
Yeah.
hope, you know, maybe now let's, you know, now the funding and the challenges are out of the way. Let's talk about some of the success that you've had so far, right? So you've mentioned, you know, you've gotten, you know, through different prototypes, you now have a product in market that I'm sure is continuing to develop. But let's kind of share maybe, you know, and bring us through an example. If you want to share, you know, the group that you're partnered with right now, you can. But if you'd like to just, you know, kind of keep that, I'm not sure if that's under NDA or whatever the case. But walk us through kind of how you're working with, you know, both hospital systems and or rehab groups and then patients today, and what some of that success has looked like for you guys early on.
The layman's terminology, when you see a smile in a patient's face, when their finger starts to move, they cry.
Mm.
Every time I see the tear, I cry too. It's priceless. I just hope there's a lot more tears all across the world from that perspective. From a success point of view, I think that is the mark of success, right? Uh, I'll give you an example of one patient who worked with us on one clinical study. This gentleman received an award for participating in the most number of clinical studies pertaining to hand. He's a retired professor,
Okay.
wanted his hand function back. And for 11 or 12 years post stroke, he's participated in all kinds of studies. Zero change in his hand. His shoulder improved and so on and so forth, but nothing in the hand. On this study, he was working with it for 15 one-hour sessions on the study, 3 weeks straight. At the end of it, he was able to cut his own steak, grab his own beer, tie his own shoelace. That is priceless. There's another professor, very, very interesting. One day I'm coming back from lunch, I'm walking into the office, he's sitting in the front, and he's like, look at me. I'm like, yeah, I'm looking at you. Can't you see? I'm like, see what? Look at my pants. I'm like, yeah, you've got pants on. The next thing he goes, that's the first time I've got a pants on with a zipper, Vineet.
Mm.
Till date, I've been wearing sweats. I said, wow, but why did you wear that? For the first time, I could pull up my own zipper. And he says this, and you can see the tears come down.
Yeah.
You know,
Goes back to those motivations, right? Like what?
yeah,
Yeah.
that is the word success.
Yeah. Yeah.
On the other side, personally, those are big to me, right?
Yeah.
That's why we all do what we do. On the other side, glad to see a device that's, the patents have been received, regulatory approvals in Canada, US, and Singapore has been received. It's gone through compliance testing. The device has been found safe in work environments. And we just sold our first devices. So that's a huge milestone because the pathway we've taken was, with COVID in between a couple of years, was really put us in a lot of jeopardy. Now we look forward to getting the device into lots more hospitals so a lot more patients can benefit on a very granular level. So right now we've got our device in either, I think a couple devices were sold, another 3 devices are what you call in clinical testing modes. They get a 1 month trial.
Yep.
So we're looking to see if it'll move to sale mode right away. In all 3 cases, we'll find out, I think, next week because their 1 month trial period is coming to an end. And roughly that's where we are right now. So
Great.
looking to a lot more success.
Nice. And is the long-term vision for these devices to also be able to go into a patient's home, or will they always be more clinic-based, where you're doing the therapy in a on-site with a clinician?
So I always give this strange example. A week has about 168 hours.
Mm-hmm.
And in most cases, therapy is provided 3 hours or 5 hours out of 168.
Yep.
If your hand really has to improve, you should probably put at least 100 plus hours because our fingers are constantly being used morning till night.
Yeah.
The more you use, the more neuroplasticity in the brain. Simple. And having said that, the current device has lots of bells and whistles to bring in all kinds of disorders that the clinicians can attend to, all kinds of hand sizes and so many different things. But for us to put a device in a patient's home, the cost has to come down.
Right.
So in the next step, in the 24-month window, we're looking to take this device, which is the size of a printer, and make it into small, medium, large, which doesn't have a whole lot of bells and whistles. Once they are set, it's easy for the patients to use at home. And the devices already come with remote monitoring, so a clinician can, get on Microsoft Teams or Google Meets or Zoom or something and talk to the patient in real time, see their hand, how it moves, and so on. So that's the next step. And both funding and time will decide how quickly we get there.
Right. And then imagine, when you're starting to go into the home, it's like the route to get it there, right? So, obviously here in the States, like digital therapeutics is a thing, right? Where, I guess it's not just in the States, but I guess the funding is starting to kind of flow there, right? Where we have a past guest, MedRhythms, right? They have a device for foot drop, and they've kind of gone. And what's difficult is what's the path, right, for reimbursement, right? So are you thinking through kind of how you're considering whether it's a device that would need to be prescribed by a doctor or physician to be able to get and then reimburse potentially through your insurer, or maybe more just like direct to consumer route, like a Sabo, that you can.
Yeah, that's a very interesting point. That's something that we kind of understand the pathway at this point. But by the time we have the device, we need to have worked through that pathway as well. That is important because that allows greater adoption. More people can benefit from it. Because if you look at, stroke incidents in the US right now, about 800,000 people get a stroke each year. And an additional 800,000 to 1 million people get traumatic brain injuries and all kinds of other problems that leads to similar problems. So you have a pretty huge population, and they are not able to go to therapy at a hospital or a clinic, either because the insurance does not cover adequately or they have to pay out of pocket or something along those lines. So if we can show the insurance companies a value that says, if this patient gets better in X amount of a timeline, then insurance doesn't have to support him for the next 10 years on disability or whatever. Or, for example, if the person hand gets better, maybe they are independent in their daily activities of daily living, So maybe they're not dependent on the insurance or healthcare system for someone to come home and help them do all those things. Or maybe that person will get back to work,
Yep.
which pays into the system.
It's the goal, right?
So we do have something called a healthcare economics study done by a company called Cital based out of Boston, and which kind of outlines these factors. But we have to go to that next stage as well and see how we could provide the value so that more insurance companies will come on board into this digital therapeutic space.
Right.
Because now the aging population is going up, which means the incidence of stroke is going to go up, and more people needs to be catered to. We have to figure out some creative solutions that makes more accessible technologies, more affordable technologies get to more people.
Yeah.
So everybody's quality of life gets better.
Yeah. And I mean, you see it starting to evolve. There's codes that just got released for mental health treatment with, as a prescribed digital therapeutics. I mean, there's certainly pathways starting to open, and hopefully, in the coming years, we'll see that become a reality for some of the things within, stroke and the rehab pathways that we're in. But yeah, fascinating kind of next stages here, I guess. Like, where do you see the next 5 to 10 years taking you guys?
Oh, thank you. I have a dream, but uh, the current spot we are looking at trying to get the devices out to more hospitals in more parts of the US and more parts of the world. So the next 5 to 10 year journey is somewhere along those lines. And the primary objective in those pathways is to get greater adoption, whether it is starting with the hospital for now and later on putting a device at home. So when a patient gets discharged from the hospital, they can go home and continue that therapy, not stop right after that. That's what's happening right now.
Right.
You want to change the model of care. And uh, uh, obviously, when you're in the world of rehab space, you don't stop with one problem. There's so many other problems that we are looking to solve, more difficult ones that can have more meaningful solutions. So over the next 5 to 10 years, we'll be putting a lot of thought into that, into other R&D projects that brings more function-specific, targeted, goal-oriented, patient-centric systems in place.
Great. So there was one thing that you're telling the story there, and one more kind of thought before we get to the magic wand here, I guess, is talking about adoption kind of resonates, and it goes back to what you were mentioning earlier with the example of one of the patients who happened to be a professor, right, that was in one of your clinical trials. I think the issue with like early stage innovation is like not enough patients know about it, right? Because this clinical trial space is so, I want to say gate kept, but like for an average survivor out there to understand and navigate how to enroll in certain clinical trials, unless you have a provider that's advocating for you and is deeply involved in academia, him or herself, like it's tough to find these trials out there, right? So how can, I guess, in your background with all the research that you've done and participated in clinical trials, and more specifically the trials that you have ongoing right now, if there's patients out there looking to potentially enroll, see if they're eligible, like what suggestions do you have for survivors, even caregivers who might be thinking about what alternative treatments there are?
You bring a very important point. The reason why the gatekeeping is strong is to protect the patient, the ethics and all of those factors, right? But at the same time, what happens is, let's say we've got a trial coming out. I can't go on TV or a radio and say, here's a study, we're looking for patients. But ideally, that would be the best way to communicate,
Yeah.
right?
Why can't you? What are the regulations and things?
So you have to get through an ethics to approve that, and it's very hard.
Mm.
Drug companies,
G-
on the contrary,
Yeah. They could
they
just go market whatever they want and put a nice jingle behind it, and say,
yeah,
take our medications. Yeah.
and I think on the research side too, that a lot of things changing. Maybe we should look at some of those options too. Traditionally, a research is done at a hospital or a clinic where a researcher is looking at things happening over time. But why not companies themselves do? And and you know that's what drug companies do. A lot of stuff that they do, they themselves do.
Yeah. Yeah.
But the challenge there is that's where the bias comes in. So that's the place where you kind of start. Because end of the day, if you do some clinical research, people need to believe the results. For them to believe the results, the less number of bias in the system, the better is the quality of the believability side on the outcomes. That's the challenge. So when we submit for these any of these research, I've noticed we use the word social media, but there also it's very limited. You're allowed to post, you're not allowed to call them, right? So you're posting, but how do you know if they actually saw it?
Right. Right.
It's a challenge, but because of that protection mechanism in place, it's hard to come around that. Some
And who,
large hospitals,
sorry,
like
who like sets those Is that like the NIH, or I mean, different regulatory bodies? Like, who's
so,
setting those?
NIH has got the guidelines,
Yeah.
and then each hospital or hospital groups would control all the patient data,
Mm.
and they're not likely to give up that data.
Right.
So, if I belong to hospital A, I submit for ethics, and in that ethics, I ask the hospital A's ethics board, could I have access to these patients? And in which case, they will say, okay, tell me exactly what you want. You
Yeah.
give them the descriptors. Somebody else will pull up patients in those criteria, and they will call them one by one and ask them if they are interested. The patient still does not have a real good idea of what's happening.
Mm.
And whoever says, yeah, sure, then I get the call. Here are these people that have agreed for you to contact them. And that
Interesting.
bureaucracy kind of puts so many barriers in between.
That's great. Yeah, I've never heard it explained. It's always like it's just the process that you have to go through for that is quite difficult. But I mean, are there wider like suggestions, because there's so much innovate again, there's so many like trials that are out there, it's just people might not know about. Are there ways that, like, obviously reaching out to your local provider would probably be one, like your neurologist, your PT, kind of see if they have any trials that they know of, like.
I think technology is going to change that.
Mm.
Because now, if you notice, 10 years ago, there are these groups called stroke recovery groups.
Yeah.
People who've had a stroke meet together once a month or twice a month, and somebody may come and give a talk, and they learn something. Nowadays, a lot of that's moving online. So it's possible that some of these advertisements have a wider network that it can access,
Makes sense. Yeah.
and that may change some of those parameters.
Mm.
Because end of the day, uh, if they don't know, see, a company wants to sell a device. Okay, it's in the business interest for the company to sell. A patient wants to buy a device or get therapy from a device, which is clinically efficient at doing that. For both of these to happen, there should be a meaningful advance on both sides. In other words, the patient should be able to test, and the test should start at these clinical testing environments, right? Where they can feel for themselves, is something getting better, yes or no?
Yeah.
Right? And so, particularly in the world of rehab, because if you look around, there are not many clinically efficient solutions out there for most problems. People get a stroke or a brain injury, and they just have to live with that disability till they die. No, that's not acceptable. There has to be a change. And participating in these trials allows patients to understand, differentiate what is snake oil and what is not.
Yeah.
Right? How this is going to change, I really don't know. Because on one side, patient data is important. Patients should be respected, not bothered on. Their rights should be respected. So all those protections in place have to be defended. On the other side, the other pathway of testing should also go through. Because let's say I had a stroke and I found out about this device, and I feel I want to buy the device. And if there was a trial going on, or if there's a clinic locally that has it, then I could go try. And then I could objectively make a decision, yeah, I'm going to buy it or lease the device. So there are lots of other benefits that comes with it, particularly in the world of rehab.
Yeah, yeah, absolutely. It's just having those options, but then I mean, again, healthcare is hard. Healthcare is regulated. Healthcare is
Yeah,
it's a
it
tough
has its
industry.
own pros and cons,
Yeah,
but
yeah,
there are certain reasons that some of them have to be there in
yeah,
place too.
yeah. Well, I think we've talked to a lot of innovators on this podcast. We've talked a lot, not too much, but we've definitely touched on clinical trials. But I think that was a very helpful overview for me, and I'm sure as well as a lot of our listeners, just the complexities that go behind, because everyone hears clinical trials as this the new thing that might be happening, the miracle drug or the miracle device that's out there, and everybody wants to probably know about it or have the opportunity to try it out. So just to understand that a little deeper, I think is helpful for everyone. But still, I think, the best thing to probably be doing if you're interested in clinical trials is just speaking to your providers and seeing if they know anything in their local, happening locally that might fit, again, your need and what's, what you could be eligible for. So
There's also a website called clinicaltrials.gov
yeah, yeah.
where a lot of the studies are registered, and it's a good place to go to.
It is. I think it's just it's a little overwhelming as well, right? Like to try to go into clinicaltrials.gov and like for a non-healthcare person, a non-academic, being able to try to understand and sift through
It's
that
not easy.
database, not easy,
Not easy.
no. But you're right. There is stuff out there. All right. Well, look, let's kind of wrap things up here. Our famous magic wand. So. We've talked a lot here on what you're doing currently, the passion that you have for the problem you're looking to solve, and really just where you see this space moving and hopefully making impact. But if you had to take this magic wand that we have, and you take that to change anything about the healthcare or specifically stroke rehab space overnight, like what would that look like to you?
Two things. We need a lot of funding
Yeah.
to make it happen.
Yeah.
Second, more patients need to know about this, and more hospitals need to know about this.
Yeah.
If they could try our device, we offer a 30-day trial. If they could try our device on their patients, they'll know the difference. So that's the two parts that we are working on right now, and pretty much working hard to get to as many care providers out there so that they could provide the best care possible for their patients. And more patients can benefit as a result. So magic wand would be money and more knowledge in the space.
Good answer. All right. Well, hopefully both of those things come to fruition for you. But yeah, look, it's been a pleasure here chatting with you, Vineet. Anything before we wrap? Any last bits that you'd like to leave the audience with?
It was wonderful talking to you, Mike. A pleasure indeed. Someone who's actually caring about what we've done, and that means a lot to me and our team at iRegained. The For more details about what we do, people can look at www.iregained.rehab. iRegained is IREGAINED, or essentially saying I regained my function. That's the reason why the company was named that way. So it's iRegained.rehab. My name is Vineet Johnson. If you've got any question, you could just shoot an email to any of our team members. Um, and more importantly, if people are interested to know where all therapy is being provided, particularly patients, if they're interested, maybe their hometown doesn't have a hospital that has the device, but somewhere else, we are happy to provide that, so they could go try it out in that different hospital somewhere else. Because our objective is, end of the day, to help more patients have access to better care. So yeah, thank you so much for taking the message across.
Of course, Vinny, it's been a pleasure, and yeah, we'll drop those notes or drop those links in the show notes, and yeah, encourage you to speak to your providers and see how many devices we get out there in into individuals' hands, because it's needed. So thank you
Yeah,
for
and
what you're doing.
for patients who want more details directly, my email is vineet@iregained.ca or iregained.rehab. You could send me an email, or you could give me a call, 807-355-6979. Thank you
Dropping
all
the
so much.
dropping the phone internet. It's no, we didn't even cover this. You're based where in Canada? Toronto?
We are 4 hours north of Toronto,
Okay. All right. So they
but
might
we
get
are,
hit with an international call rate if they give you a call, but
and
it'll be for an
soon to
important
be
call.
setting up shop in the US. So
Okay. Good, good, good. Well,
yeah,
excited for that. All right, Vineet. Well, it's been a pleasure here. Wishing you all the best. You're doing impactful work, so keep that up, and
thank you so much, Mike.
all right.
Pleasure.
Take care.
Cheers.